Arterial blood gases, or ABGs, provide key data on oxygenation, ventilation, and acid-base balance governed by the lungs and kidneys. An ABG report includes pH, which is the hydrogen ion concentration denoting acidosis if below 7.35, or alkalosis if higher than 7.45. PO2, the partial pressure of arterial carbon dioxide measuring respiratory effectiveness. PaO2, the partial pressure of arterial oxygen gauging oxygenation. HCO3, the bicarbonate level, implies metabolic function. BE, or base excess estimating extra base or acid. And SaO2, the oxygen hemoglobin saturation percentage. Analysis determines if abnormal values indicate respiratory and/or metabolic origins, guiding medical management of hypoxia, ventilation inadequacy, acidosis, or alkalosis, ultimately optimizing oxygen delivery. ABG interpretation involves 1. Evaluate pH to categorize acidosis or alkalosis. 2. Examine PO2 to classify respiratory versus metabolic cause. 3. Compare bicarbonate to PO2 to confirm diagnosis. 4. Determine treatment based on underlying dysfunction. Respiratory acidosis is indicated by an increase in PaCO2 and a pH less than 7.35. Treatment involves addressing the underlying lung problem, such as infection or COPD, and ensuring adequate ventilation. Respiratory alkalosis is indicated by a decrease in PaCO2 and a pH greater than 7.45. Treatment involves addressing the cause, such as pain or delirium, and may include sedation or ventilator adjustment. Metabolic acidosis is indicated by a decrease in HCO3 and a pH less than 7.35. Treatment involves addressing the cause, such as diarrhea or DKA, and may include bicarbonate administration. Metabolic alkalosis is indicated by an increase in HCO3 and a pH greater than 7.45. Treatment involves addressing the cause, such as vomiting or diuretics, and may include an acidifying agent. Compensation occurs in chronic conditions until acute changes disturb homeostasis. Respiratory acidosis occurs when impaired ventilation fails to adequately exhale CO2, resulting in CO2 retention and H+ accumulation, reducing pH. Causes include acute asthma exacerbation, pulmonary edema, pneumonia, exacerbated COPD, respiratory muscle fatigue, and drug-induced hypoventilation from opiates or sedatives. Support oxygenation and optimize ventilation to reverse risks of cerebral vasodilation like disorientation, headache, and even coma in extreme acidosis. Intubation with mechanical ventilation quickly restores acid-base balance in significant cases by increasing alveolar minute ventilation, eliminating CO2 while administering high FiO2 oxygen. Respiratory alkalosis manifests when enhanced ventilation blows off too much CO2, triggering pH to rise 7.45 as carbonic acid decreases. Main categories involve central and peripheral causes like head injury, stroke, sepsis, fever, hepatic failure, hypoxia from pulmonary embolus or pneumonia, pain, vomiting, pregnancy, and medications like salicylate toxicity. Identifying and correcting the underlying cause typically normalizes pH. Supportive care meeting metabolic needs aids recovery for severe marginal cases until homeostatic mechanisms restore equilibrium. Metabolic acidosis occurs when HCO3 loss exceeds lungs' ability to compensate via renal reclaim and respiratory mechanisms, triggering dangerously low pH from insufficient buffering capacity. Main causes stem from uncompensated GI losses like diarrhea and intestinal fistulas, toxins disrupting cell metabolism such as diabetic or alcoholic ketoacidosis, lactic acidosis, and renal dysfunction. Identifying etiology targets specific interventions correcting acidosis. Fluid resuscitation supports organ perfusion. Bicarbonate administration replenishes alkaline reserves. Dialysis removes accumulated toxins. Addressing underlying trigger resolves additional lung compensation need. Metabolic alkalosis manifests when excess bicarbonate shifts pH above normal range, impairing protein function. Primary causes include chloride depletion from extensive vomiting or nasogastric drainage, diuretics like furosemide, excess bicarbonate ingestion or infusion, and hyperaldosteronism from conditions like cirrhosis, malignant hypertension, or adrenal adenoma. Kidneys normally excrete excess bicarbonate but take days to eliminate chronic accumulations. Causing conditions must resolve while balancing potassium and magnesium levels to reestablish equilibrium. Fixing volume status curtails hyperenanemia. Monitoring progress informs supplementation adjustments targeting alkaline reduction toward recovery.